National Health Insurance Authority, North Central Zone was in August 2001. Before, the zone comprised of Kwara, Kogi, Niger, Plateau, and the FCT. So because of the increase in our operations, some of our zones, particularly the North Central and Northwest zones, have been further broken down. So we now have the North Central, we have North Central A and North Central B. North Central B is made up of Kwara, Kogi, and Niger states, with the headquarters here in Kwara State. Though we have been engaging with some of the media houses on a one-to-one level, this particular event provides a great opportunity for us to meet with many journalists at the same time. The National Health Insurance Authority has been undertaking to reposition the authority to adequately respond to the challenge of attaining universal health coverage, which we call UHC, by the year 2030. This target here is based on the presidential mandate, and it is also in line with the Sustainable Development Goals of the United Nations. Some of the reforms that we have undertaken call a 3-point branded agenda, which has value system orientation, promoting transparency and accountability, and accelerating the drive towards achieving universal health coverage through consolidation of existing programs and embarking on innovative activities. On the 19th of May 2022, our President, Nhia, retired this year, as far as we are concerned, the authority made history by signing the National Health Insurance Authority Act 2022 into law. For us, this is a landmark legislation and is bound to significantly affect the health insurance ecosystem in very positive way. Some of the highlights of the law are, we now have a change of name. People are familiar with NHIS, National Health Insurance Scheme, but the new law makes it National Health Insurance Authority, NHIA. A lot of us are still trying to get used to the transition. But it is not just a change in name. You know, sometimes people will ask you what is the name, but there are a lot of things in the name. Now that we are an authority, we are empowered, we have more powers. Another thing that I think I want us to take away to the act is the fact that by law now, the NHIA is bound to promote, to regulate and integrate all health insurance services in Nigeria. We promote, we regulate, and we integrate. Before now, there has been a lot of arguments. Is NHIS a regulator or an operator? But by this law, we can both operate and we can also regulate. It's the same way that the central bank does not render commercial bank services. The central bank regulates the banking industry, but the central bank is also the government bank. So it's also a banker to the government. So it's also in the same spirit. The law provides for review of tariffs every 3 years and our operational guidelines every 5 years. I know during the question and answer session, a lot of questions will come in because people would say that our tariffs are not responsive to the economic demands. But now, the law says these tariffs are reviewed every 3 years. The current operational guidelines that we are using was last adopted in 2012, although we started improving on it. But again, now with the law, we don't have that law. Every 5 years, by law, we must review the operational guidelines. And the state social health insurance agencies are now empowered to provide care for all Nigerians, with the exception of federal public servants and all other residents. So what happens now is that because participation and uptake of insurance activities at the level of the states has not been quite commensurate with the efforts, a lot of things have been happening at the center. But now the idea is that we will devolve to the states. So apart from insurance cover for federal government employees and federal government agencies, any other person who is in Nigeria must purchase health insurance from the state social health insurance agencies. Then in the law, there is a creation of a vulnerable group fund, which is to cater for the poorest of the poor, the elderly, and other vulnerable sections of the population, such as pregnant women and children under 5. This fund is going to provide subsidy as it were. And when the president signed this act, he made it clear that the government is committed to enrolling 83 million people through the National Health Insurance Authority to be able to get cover. Those are the people who cannot pay. And because the principle of universal coverage requires that everybody must be covered. But insurance, you have to make payment. The idea then is that those who can pay must be made to pay. And those who cannot afford to pay, or those who don't have the ability to pay, must be paid for. The law now makes health insurance mandatory, and the NHIS will enforce the provisions of the basic minimum package of health services. What we are saying is that everybody, either you are employed by federal government or state government or self-employed or whatever, you must have health insurance. And in fact, it is an offense not to have health insurance. And because there is an offense, there are also penalties. Any employer of labor with more than 5 staff is required to obtain health insurance for its employees. So for some of us who on the sides do other things, we have more than 5 staff. Even if you are running a supermarket and you have more than 5 staff, the law requires that you must purchase health insurance on their behalf. And the implication is that the employer will pay and the employee will pay. Usually our ratio is that the employer pays 10% of the basic salary and then the employee pays 5%. Because ultimately the employee must take responsibility for his own health. The employer also is bound to take responsibility for the health of his workforce. States from every geopolitical zone now have a seat in the governing council, and it is by rotation within the zone. Before that, because the law now recognizes that there must be linkage and cooperation between the state health insurance agencies and the National Health Insurance Authority, the law provides that each geopolitical zone will have a representative on the governing council. And that is going to be by rotation. And it is usually for 2 years for those states. For example, geopolitical zone, North Central. If Kwara sends a representative to the council in this session, that representative will spend 2 years. At the end of his own 2 years, another state from the North Central zone will also bring another person. So that at the end of the day, everybody at one point or the other is aware of what is going on, and they are also involved in policy making. The law provides for 2 broad categories of health insurance. Mandatory. For the mandatory, it is either that somebody is paying or somebody is being paid for. That's the one we call subsidy. And the other one, which is private, which will be run by HMOs and other registered bodies. They are supposed to render both supplementary and complementary services. In the new law, there are new and modified rules for stakeholders, including HMOs, healthcare providers, third-party administration, state health insurance agencies, and the Honorable Minister of Health. And one will be wondering, what is it? In our previous law, the Honorable Minister was empowered to give directives of a general nature to the governing council. But in the new law, the Minister can only give directives to the governing council on policy matters. It is specific. Before, it says it can give directives of a general nature. And you will understand in the history of our organization, we have had chief executives who will tell you that I don't report to the minister. But by this law, any issue of policy, the minister can give guidance to the council. Another aspect of the law is that we need to know that the implementation of the act has started, though we are still in transition. It's our considered opinion, therefore, that with the cooperation of stakeholders, the NHI is, of course, to achieving its leading to improved access to quality health care and better outcomes in the health sector. Now, we are speaking about universal health coverage. So what is it? By the WHO, universal health coverage is ensuring that all people have access to needed promotive, preventive, curative, and rehabilitative health services, which is of a sufficient quality, while ensuring that people do not suffer financial hardship when paying for the services. What we know here is that people pay out of pocket. If somebody is sick and he wants to go to the hospital, he must go with money in his pocket. It's like you are going to the market to buy something, so you have the money. But because health can knock in, health can come in even when somebody does not have money. And that is why health insurance provides a prepayment mechanism so that ahead of falling sick or requiring health care, because it is not everything that takes people to the hospital that is sickness. Like I keep saying, pregnancy is not a disease. The people who are pregnant, they will require antenatal care. They will require postnatal care. So such things. So with health insurance, people are able to pay ahead. But because it is also insurance, what you are paying for may or may not occur. And so for WHO, if we are saying we want to achieve UAC, everybody in the population must have access to whether curative, preventive, or rehabilitative healthcare services. And that is important. Now, for UAC, there are three basic dimensions. There is a cost dimension, which is financial. There is the population dimension, and there is the service dimension. For those of us who are familiar with the literature, UFC is represented with a quibbot. One is that there must be money. You cannot provide services without investing some money. So that's the financial aspect. Because usually we say that in healthcare financing, there are two sides. The demand side and the supply side. The demand side are the people who want to go to receive healthcare. The supply side is represented by the healthcare facilities. So there must be an interface. So someone must have money. And that's why we say it is financial risk protection. Because what it means is that if you don't have insurance and you don't have money in your pocket, you cannot go to the hospital to access it. Then with insurance, you may not have that money at that time. But because you have been contributing ahead, when ill health comes, you just walk in there and take the services. And then the population, how many people are covered? If you say it is universal, it is universal. It means everybody must be covered. But like we said, it's not everybody that has the financial power to pay. And then the services. What are the range of services that are provided? That is the benefit package. You will hear people who say that they go to the hospital, they are under NHIS, and they say that this is not covered, it is not covered. For social health insurance, you cannot cover all conditions. But what you can cover is basic minimum package of healthcare services. And for us in Nigeria, the basic minimum package is provided for in the National Health Act of 2014. And that takes care of the common conditions that are available in that community. So once you have a basic package that addresses the challenges of the community, then and they can access those services, then you have those. For example, I had the privilege of working with the Honourable Minister sometimes in the past, between 2003 and 2007. And when we were doing polio campaign, we went to a place called Katabu, and then we saw the area and spoke about the need for them to bring out the children for polio immunization and all of that. And that time there was a lot of controversy about polio. And the area, when we went to pay a constable with him in the palace, he said, Honourable Minister, we know polio is good, we know vaccination is good. But here in this community, our problem is not polio, it is snake bite. Because if you are familiar with that part of Nigeria, that is the major common public health challenge. So in that community, if you give them an health insurance package that does not include treatment for snake bite, we have not done anything. So our package must be community responsive, must be responsive to the local needs. And that's what you have with with respect to the range of services. So the NHI works within the financial aspect of this, which deals with the demand side. In recent times, the efforts to achieve UAC by the authority has focused on some activities which are briefly highlighted. Because we know that we must achieve UAC, we have a 10-year strategic plan, 2020 to 2030. And this plan gives us goals and activities and targets to achieve, among which we, as we begin to embark upon these activities, will be able to achieve UAC by the year 2030. We are also completing the short-term plan, short-term phase of it, because it's a 10-year plan, so it's grouped into 3 years. The last phase is 4 years. So by the end of this year, we'll do the first phase review. In 3 years of the strategic plan, how many people have been covered, how many people have enrolled on health insurance, and what services are provided. We have also embarked on the implementation of the Basic Healthcare Provision Fund in line with the National Health Act 2014 to take care of pregnant women, children under 5, the elderly, through the NHI institute. In the Basic Healthcare Provision Fund, like I told you, we have in health finances demand and supply. For demand, it is National Health Insurance Authority. For supply, it is the National Primary Health Development Agency, because they have the healthcare facilities. So we call our own the NHI gateway. Then we have the NHCDA gateway. We have also introduced a program that we call the Group Individual and Family Social Health Insurance Program, which the acronym is GIFSH. This is a product that allows every individual, families and groups, either by location or population, to purchase health care at affordable cost. What are we saying here? You can have a group. That group can be by geography, by location. For example, you can have a group of, say, journalists. You can have a group by occupation. Journalists, MBA, lawyers, and all that. But you can also have a group by geographical location. You can say target community. So what you do is that you have defined target. By Quara, you have defined a location. So with the payment for these services, we think that we can make a lot of progress. And this product of gift ship, we have 4 types of it. We have what we call the gift ship G, which is general, anybody can buy, individuals, families, and groups. And then we have gift ship R, this one is for retirees. Because we know that usually it is when people retire that they require more access to healthcare. Because at that time, conditions of old age, some of them are diseases, some of them are not diseases. The conditions of old age begin to set in, and then they are no longer in service, so the work cannot make, they can't earn much. And we think that makes their empowerment process better. Because if you empower them, if they are healthy, you have already empowered them. They will be strong to undertake vocations, family, and all kinds of things to do. And the final one is the gift M, which is targeted at NYS. And for this, the gift M in particular is for core members. And it was flagged up in 2022. And we have continued to provide cover for all NYS members from the point of mobilization to discharge. We have also improved our operational efficiency through what we call the NHI Medicine Supply Initiative. Before now, one of the complaints that we hear is that people go for under NHIs or NHIs that they are given inferior drugs. But now we are branding our own drugs. I know a lot of you are familiar with PTF drugs those days. You are familiar with PTF, all of those things. So we will brand those products. They will carry those medicines, will carry the logo of NHI and then the logo of the manufacturing company. And they will only be available for distribution at NHI accredited facilities, hospitals, and pharmacies. And we believe that that will bring down the cost of drugs, and that will also provide access to quality drugs, so that people will not be complaining that it's only chocolate or paracetamol that they're giving them. That's what our NHI supply initiative. We have also developed standard treatment protocols for various levels of care. I tell people, the way a community health worker in a basic healthcare center will treat malaria is different from the way a consultant GP in a teaching hospital will treat malaria. If you go to the health center and say, I have malaria, they will not even ask you any questions. give paracetamol, I'll give you antibiotics. But you go to the teaching hospital, you tell the man, I have malaria. The next thing you say to me, who told you? How did you know? By the time you now explain the symptoms that you are feeling, it doesn't even start treating you immediately. He says, so you go to the lab, go and run the test. The best thing to do for you is just to give you an diagnostic, just to stabilize you. So we have standard treatment protocols for every level of care, because we are not asking people to play God at the level of care. And then we have also a strategy for healthcare facility responsiveness and accountability framework. I had the privilege of working on that document. We also have leadership development programs and signing of MOUs with local and foreign institutions. Now we are training our staff by developing them. Some of us have benefited from training from the Lagos Business School. Some are on scholarship at Mahidol University in Malaysia and a number of other places like that. And then we have also improved our relationship with state health insurance agencies and funding them within the framework of the basic healthcare provision fund, which again we are also working on under the health insurance under one roof agenda, and we engage with stakeholders. These are some of the things that we are doing so that we think we can achieve it.
Welcome back from that background report. Morning Safari is the program. You will agree with me that Nigeria as a nation since 2004 has been struggling to revolutionize the health sector by introducing National Health Insurance Scheme, that's NHIS. Speaking of NHIS, of course, you know, everybody can really relate with that name, NHIS, ensuring the health of all Nigerians. But unfortunately, the scheme has not really done well in covering even up to 10% of the population. Hence, the need to give birth to a new act that would cover almost everybody and ensuring the lives and health of many Nigerians. Now, how much do you know about the new act of the Nigerian health sector? This is actually what we are looking at this morning, and how does it intend to actually take it beyond the former NHIS. NHIA is the new act, and this is what we want to talk about this morning. To discuss this, we have with us this morning the General Manager, Zonal Coordinator in charge of the North Central A, Kwara, Kogi, Niger, in person of Mr. Adelaja Abirioran. It's a pleasure to have you on set with us. I hope I got the last name, Abirioran, right?
Yes, Abirioran, you're right. Thank you very much.
Yeah,
Good morning, viewers. Thank you for having me.
Thank you very much for honoring the call. Now, let's start this discussion by, first of all, looking at the name NHIS. You know, the saying goes by, behold, the old has gone and all things become new. Now, like I said from my introduction, the National Health Insurance Scheme has not really covered so much in ensuring the lives of Nigerians, even up to 10%. And now we're having a new act, you know. Is it actually what is the new act all about actually? Is it repealing the old way, or is this just a way of changing the name? What does it stand for?
Okay, thank you very much. Maybe just a few remarks, and just to put a few things in context. The law establishing the National Health Insurance Scheme was signed in 1999.
Okay.
The first legislation.
Okay.
We are conscious of the fact that the issue of health insurance was actually mentioned for the first time in the Nigerian Parliament in 1963.
Wow.
But between 1963 up to 1999, all that the nation was doing was to see how to start. And sometimes when there were a few committees set up here and there, but in 1999 the act was signed, and then the NHIS then became a legal entity. And between 1990...
It became a legal entity.
Yes, a body corporate, because that law established it.
Okay.
So you are talking of a juristic person.
Okay.
That the scheme is a corporate body.
Okay.
Now, between that time and 2005 precisely, there were a lot of programs, especially the community-based schemes, where you get mutual health associations across the nation. Actually, there were pilots in all the geopolitical zones to see how this can go on. But between 1999 and 2004, some of those efforts had some measure of successes.
Okay.
But in 2004, a lot of things started to change, precisely because you had somebody in the driver's seat who has health insurance as a passion, and that was when Professor Itayo Lambo was the Honorable Minister of Health from 2003 to 2007. And I had the privilege of working with him as one of his assistants at that time. And so the point was that beyond the community schemes, let's get into the formal sector. And the formal sector for us was a low-hanging fruit that we needed to start with. But of course, there were a lot of challenges of personnel, challenges of technology, and all of that. And the idea was that, okay, let's start with the formal sector. At that time, the state governments were not ready to be part of the federal government initiative. So what the government did then was to start with the federal public servants. So all of them were enrolled. And health insurance is a contributory program. For us, we are running a social health insurance, where you have people who can pay, are required to pay for those services. Those who cannot pay are to be paid for by way of subsidy. So for those who are in employment, formal employment, the provision was that the employer pays 10% and then the employee pays 5%, because the employer needs healthy employees to continue to be able to work for him and produce wealth. The same way the employee also needs good health to be active at work. And so that's what we had, and we had that going on for quite a long time. And that possibly was one of the things that accounted for the level of coverage. But along the line, we said, okay, let's devolve to the states.
What happened to the level of coverage, actually?
The scheme, because like I said, insurance is contributory. The scheme as we have, people give a lot of figures. But if you know that you can only cover those who are paid for. And for us in the National Health Insurance Authority as we have now, I'll come to the issue of the change of name. Our mandate based on those who are paying, federal public servants. And I dare say that we have covered more than 99% of federal public servants, because those are the ones that were paying. Now talking about the generality of Nigeria,
which is the population of
which
around
is the general population,
over 200 million.
The mistake that people also make is that when you talk about health insurance, the NHIS then and NHIS now is not the only actor in that field. There were private health insurance schemes, and by the time you pull the health insurance figure with the one from the private schemes, with the one from the community schemes, we are above single digits. I may not be able to tell you that this is the precise percentage, but I know by the time you put all of those together, because we're talking about insurance. Insurance could be private, it could be social, mandatory or supplementary or complementary. So by the time you add all of those figures together, we are above single digits.
Well, anyway, since the success of the NHIS is actually based and measured on the federal system, you know, we would say that, well, the NHIS might not really have met with the demand of the population. Of course, Nigeria has the whopping figure.
Very correct.
Very
like
correct.
I said, that's the challenge that we have.
So now let's talk
know
about
that in this country. Sorry, let me just clear this so that we don't miss it. We said that we're a federal structure.
Yeah.
Now, when it comes to sharing federal revenue, the states come to Abuja, they collect revenue. But when we now say, okay, bring this revenue that you have collected from the center
to cover for your people. That is when you hear the state saying, look, we are federating units. We have a right to spend our money the way we want. And that's why I say if states go to Abuja to collect allocation, they should not be opposed to collecting responsibility even from the center. Because the challenge that we have now, it is only the 1979 Constitution that put health on the concurrent list. Going by the 1999 Constitution as amended, health is nowhere. It is neither exclusive, it is neither concurrent, it is neither residual. So, and that is why we felt that, look, beyond federal lives, because the truth is that there are no federal lives. We are all Nigerians.
Yes.
Some happen to work with federal government, some work for state government. Some are in private sector employment, some are in public sector employment. So what you then have is that you need to get the states to start doing something. And that was why we started saying that, look, let the states also set up their health insurance agencies so that at least they can also cover the lifestyle. But the good thing about the new law, if I can come to that right now, is the fact that the new law allows the National Health Insurance Authority to cover only federal public servants.
Okay. The new law?
The new law.
Okay.
Every other person in Nigeria must buy health insurance through the state social health insurance agencies.
Let me take you on the choice of word used right now.
Yes.
You said every Nigerian must. Let me underline that must.
Okay, I will
Are
explain
you
that.
trying to say that if something becomes authority,
Yeah,
it is an act?
yeah.
Now, should you now say that the word must used here is simply coining into compulsory kind of or mandatory?
Precisely that is the word.
So does that give birth to the new law?
Precisely, if you go to section 3A of the new law, the National Health Insurance Authority Act 2022, signed into law by the President on the 19th of May. 3A says that the National Health Insurance Authority shall promote, integrate, and regulate health insurance in Nigeria. 3B says that the authority shall ensure that health insurance is mandatory for all Nigerians. And if you go to section 14.1, it says that every Nigerian and legal resident shall be required to obtain health insurance. In fact, the law criminalizes not having health insurance.
Now,
so it is mandatory.
It is mandatory.
Mandatory.
Okay, so this takes me to yet another question. Now, it has become an act now, which mandates everybody. It is all inclusive, so to say. Health inclusiveness and the rest of it. Now, what are the possibilities of achieving universal health coverage (UHC) by year 2030 as directed by Mr. President, while signing in that act into law?
Anyway, thank you. Before the signing into law of the NHIA Act 2022, we already had a presidential mandate way back 3-4 years before to achieve UHC by 2030.
Okay.
So now what is our journey to UHC? For us as an organization, because the point is that, like I have said, we are just the leading agency. Every other person will need to come on board. There are stakeholders, state health insurance agencies, health maintenance organizations, HMOs, healthcare providers, even individuals, corporate bodies, and everybody. Now, for us, before the signing into law, shortly after that mandate, one of the things that we did as an organization is to have a 10-year strategic plan, 2020 to 2030.
Okay.
And in that strategic plan, we had goals, we have objectives, we have what we call priority areas, we have what we call pillars, priority pillars, and then a lot of activities that we think we can do. And like I did say in my press briefing yesterday, when I interacted with a journalist at the NUJ Press Center here in Ilorin, I mentioned that by the end of this year, we'll be concluding the first phase, the short-term phase of that 10-year, where we'll be reviewing the activities, how far have we gone, because the implementation of the plan is divided into three.
Okay.
3, 3, 4. The first 3 years is our short term, the next 3 years is our medium term, and then the next 4 years is the long term. So that by the time we are concluding 2030, we can be sure that the journey to UHC has been significant. And I believe, like I said yesterday, UHC is achievable in Nigeria, given one, the programs that are put in place, given the implementation of the Act, and given the collaboration and cooperation of all stakeholders.
Okay.
If we have all of this in place, I am sure that we can meet that presidential mandate.
Now, speaking of stakeholders, involving in this, in the achievability of this act now, or the dream, how do you want to deal with compliance?
Very good. Thank you. In our organizational structure, we have also had to do a lot of restructuring in-house.
Like, to be specific, some state governments might want to come up with stories, and the rest. So how do you want to sustain that drive?
Well, like I said, we are reforming. We have an enforcement department.
Okay.
But beyond the enforcement, one major thing that we are doing is to engage with state governments and state health insurance institutions. In fact, we have a framework that we call health insurance under one roof, which is to bring every actor in that ecosystem to come under a platform such that it becomes easier for the NHIA, as by law, to be able to integrate and regulate. Okay. So we are both an integrator, we're a promoter, and we are a regulator. And that's what the law says. Now, even the law recognizes that there is a 2014 Act, the National Health Act, and then Section 11 there provides for the establishment of a basic healthcare provision fund. In fact, by the 2022 National Health Insurance Authority Act, if a state does not have a social health insurance agency, they cannot benefit from the provisions of the basic healthcare provision fund. And that is why you've discovered that in the last 3-4 years, a lot of states have now established their healthcare, their social health insurance agencies. The law recognizes that if a state does not have an social health insurance agency in place now, they can use what we call TPA, a third-party administrator. But as it is, I think out of 36 states, we have about 35 that have signed into law the establishment of their state agencies. And then I think out of that 35, I think about 33, 34 are already operational.
Now, before we call it a wrap on this segment, I just want the viewer, a layman out there who is probably living in a rural, remote area as we speak now, and who wants to benefit from this scheme, from this program now. How can a layman living, far off the city, benefit from this program?
Well, that's a major challenge, because we recognize that the vast majority of our people are living in rural areas. Okay. And access to health is critical. Now, for us as an organization, we have a program that we call GiftShip. Okay. Group, individual, and family social health insurance. Anybody, everywhere, anywhere can purchase health insurance under that program. Okay. And the way we are doing it, when we started it, yes, people need to come to our office, and we have offices in all the 36 states of the Federation. People need to come to our offices and do this. But we are embarking on the technology platform. We call it the eNHIA. Okay. That is electronic NHIA, such that within a short time from now, everybody who has access to a mobile phone will be able to purchase health insurance on his or her mobile phone. Okay. Apart from the fact that our state offices are going into various communities to sensitize people. But over time, that responsibility will be for the state social health insurance agencies.
Thank you very much for coming on the show to shed light on the gray areas regarding the new act, National Health Insurance Authority, the new act. Thank you very much. It's been an organic conversation with Mr. Adelaja Aberioro, who is the General Manager, Zonal Coordinator in charge of North Central A, Kwara, Kogi, Niger. Thank you very much. It's been a wonderful time with you. Some other time we'll bring you to maybe shed more light on certain gray areas. I wanted to actually ask you, but maybe time could not permit us, with regards to the people living in the country who are not actually from Nigeria, but they are staying here. Can they also benefit from it? Maybe some other time.
Well, okay. Thank you for having me.
Yes or no?
But yes, because the law actually says that all Nigerians and every legal resident.
Okay, thank you very much.